Hello. So,
Yes.
sir, is 3, 2, 1. Over to you, sir. We are live to audience.
Good evening, everyone. My name is Dr. Talha Miran. I am a heart failure and transplant cardiologist based in Mumbai. Welcome to this fourth webinar hosted by the Society for Heart Failure and Transplantation India with help from JB Pharma. The topic for today is the role of ARNI in post LVAD recovery. Our speaker for the event is going to be Dr. Manoj Durairaj, who is also the secretary for the Society for Heart Failure and Transplantation India. He's the immediate past president of the IACTS and is the program director and head of the Heart and Lung Transplant Program and MCS program at Sahyadri Hospital in Pune, in addition to his role as the director at the Marian Cardiac Research Center based in Pune. Along with me, moderating the session today is going to be Dr. Aditi Singhvi, who is herself the clinical lead and the heart failure and transplant cardiologist from Narayana Institute of Cardiac Sciences in Bangalore. We have an expert panel consisting of surgeons from all across the country. We have Dr. Professor Vivek Javali, sir. He's the past president of the IACTS. He's currently the chairman of cardiovascular sciences for the Fortis Group. And he is well known for his work all across the nation, especially for coronary work as well as advanced heart failure and transplant. We will be joined by Dr. Kunal Sarkar as well. Dr. Kunal Sarkar is the Chief Cardiac Surgeon and Director of Cardiovascular Surgery at Medica Super Specialty Hospital in Kolkata. He's also one of the past presidents of IACTS as well as the Society for Coronary Surgeons of India. He's traveled well across the country as well as abroad, speaking on various issues related to cardiovascular surgery and advanced heart failure. We'll also be joined by Dr. Manoj P. Nair, who's the lead consultant cardiovascular and thoracic surgeon based in Aster Medicity in Kochi, Kerala. He is also a prolific surgeon and is one of the inspectors for the National Board of various academic courses in India. The topic, as I said, is the role of ARNI in post-LVAD recovery. We know that LVADs, left ventricular assist devices, have become one of the go-to therapy for end-stage heart failure, in addition to cardiac transplant. As we all know, LVADs can be put in as destination therapy. And more as time goes on, we have realized the role of LVADs helping in left ventricular recovery. Today's topic is going to focus on the role of medical therapy, especially focusing on the role of in post-LVAD recovery. As I said, we'll let Dr. Manoj Durairaj sir take over and guide us through the topic over the next 25 to 30 minutes. After that, we will open up the discussion between me and Dr. Aditi with the panelists. And at the end, hopefully, we will have time to take questions from the audience. Dr. Durairaj, thank you for joining us. We look forward to learning from you.
Thank you, Dr. Thala, and I hope I'm audible.
Yes, sir.
Are the slides visible?
Yes, sir. Perfect.
Yeah. Thank you so much. On behalf of the Society for Heart Failure and Transplantation, I'm so thankful to Dr. Thala and Dr. Aditi for taking the lead for our academic programs. This is a series of webinars which we are conducting nationwide. And today we have industry partner, JB Pharma, And I'd like to thank Dr. Amil Roy and the industry for supporting this program. We are looking forward to exciting panel discussion, and I'll keep the presentation short so that we can have a lot of question-answer discussions. It need not be pertaining to LVAD alone, but it could be related to pre and post-transplant workups also. So I'll be talking about specifically the role of ARNI, and this should set the stage for the panel discussion which will follow. Why does this topic matter? LVAD implantation provides a mechanical bridge to transplant or a bridge to recovery, and in instances, especially abroad, as a destination therapy. Why does this matter to us? Because most of our patients, if they are not doing too well on an LVAD and we can't get them off the LVAD, it becomes a challenge for us. Especially maintaining an LVAD for the long term becomes an issue in a country like India, with its due problems of driveline infections, strokes. So there is a chance that we might be looking it for as a bridge to transplant. We'll be looking at this therapy as a bridge to transplant or a bridge to recovery. There are persistent issues which happen like neurohormonal activation, residual heart failure symptoms, and here there is an increasing role of guideline-directed medical therapy to improve the long-term outcomes for these patients. As I told you, it can be a bridge to transplant, it can be destination therapy, or we can look at it as a patient where we can get the patient off the LVAD and the patient leads a normal life post that. The pathophysiology after the LVAD implantation is it reduces the LV wall stress. There's a potential for reverse remodeling with mechanical unloading. There is an ongoing neurohormonal activation and hence reduction in the myocardial fibrosis. So can happen when we have an LVAD. And also definitely there's a need for pharmacological support to enable true myocardial recovery, especially for the right ventricle. Continuous flow LVAD reduce the pulsatility and also activate neurohormonal pathways. And because of reduced pulsatility, there is an activation of the RAS system, the structural damage because there is a myocardial fibrosis and ventricular stiffness which can ensue. Also, there could be incomplete reverse modeling despite the mechanical support. And this is the fill in the blanks or the gray areas where GDMT can help us. So how does it help? In a pre-VAD situation, there is RAS activation. And because of that, there is an increase in aldosterone and hence there is an increase in sodium and water retention. There is vasoconstriction, fluid retention, and a higher blood pressure. If we inhibit this by post-VAD situation, you can see that all these adverse effects are negated. But can we add something else to this whole mechanical component? Yes, we can have guideline-directed medical therapy super added to the mechanical circulatory support. The GDMT, which we are looking at in this day and age, are ARNI, MRA, beta blocker, and SGLT2 inhibitors. What are the guideline recommendations? The International Society for Heart-Lung Transplantation and the major heart failure guidelines strongly emphasize that we should continue GDMT for patients with ailments. This helps to address residual neurohormonal activation, promotes reverse remodeling, and also improves the long-term outcomes. The Heart Failure Society expert consensus statement states that we should have certain core principles in having an LVAD on board. One is a multidisciplinary care, which also includes an LVAD infection prevention protocol like proper dressing, avoidance of water on the things, antibiotics, drainage operation, a lot of stuff. Also, it has in that protocol guideline-directed medical therapy. So in addition to a multidisciplinary care, which you can see on the left side of the screen, you also need to understand that medical therapy also matters quite a bit. Other than device optimization, monitoring, fluid intake, and various other LVAD-related care. So multifaceted medical management of LVAD patient includes as a priority GDMT also. This is the consensus statement. And how does that help? Now, ARNI is containing sacubitril and valsartan. Valsartan obviously ensures that there's an 18 angiotensin 1 receptor blockade, and hence RAS-driven remodeling can be reduced. Sacubitril improves the availability of ANP, BNP, and CNP peptides, natriuretic peptides. Because of the neprilysin inhibition, it also increases the levels of bradykinin, GLP-1, adenomedullin, which helps in vasodilation, reducing the sympathetic nervous system activity, especially with continuous pulse, LVAD mechanisms. It increases the parasympathetic nervous system activity, increases natriuresis, diuresis. It causes a favorable cardiac remodeling, reduces the cardiac fibrosis, hypertrophy, and also importantly, it reduces the risk of arrhythmia. ARNI, when we look at post-PTCA, post-CABG patient, reduces the risk of sudden cardiac death by 20%, and most of these cardiac deaths are because of ventricular arrhythmias. And this is a known fact which is being seen in the PARADIGM-HF trial. This innovator, ARNI, changed the face of heart failure treatment with the PARADIGM-HF trial, and it has been going on for almost more than a decade, that it has been a blockbuster molecule as compared to just a plain ACE inhibitor or an ARB, which works with a single pathway. In ARNI, we are looking at a dual pathway, and I've also mentioned it previously that this dual pathway works by improving the natriuretic peptides as well as inhibiting the angiotensin mechanism, the RAS inhibition. So it targets both the pressure as well as the remodeling simultaneously. In addition to this, it has also a lot of cardiomechanistic actions, which is directly on the cardiomyocyte. So it has got a pump and pipe effect, and that is where ARNI plays a very in reverse remodeling for the the damaged myocardium, as well as protecting the right ventricle. And in most cases, it helps us to explant the LVAD, and it works, and we can use it like a bridge to recovery. Now, this is a trial, which is the NVAD trial. I'm sorry. It's called the NVAD HF trial. It is a multi-center randomized open label parallel group study to evaluate the use of ARNI in HeartMate 3 LVAD recipients. This trial was published in JACC Heart Failure 2020. I'm sorry for the printing mistake here, but it's a fantastic trial which compares 60 patients, 30 patients head-to-head with standard of care, and when we are using sacubitril valsartan. The primary endpoints were all-cause death, deterioration in renal function, hyperkalemia, or symptomatic hypotension. When you look at the Kaplan-Meier, the graph, the time to the first composite endpoints is definitely reduced, and numerically fewer occurrences happen for the primary outcome, which is out here, when we use an ARNI. Also, there are a few things. There is a safety and efficacy which favors sacubitril valsartan over standard of care. The significant reduction in blood pressure medications and improvement in the Kansas City cardiomyopathy scores, which are also very, very important when you're looking at symptomatic relief for these patients. You might not have, especially in patients who come with de novo heart failure, you might not have symptom, the dramatic change in the LVEF, but you'll have a dramatic change in the symptoms of these patients. And that is where ARNI and the other SGLT2 inhibitors score over other molecules. Now, this is important when you have a temporary MCS like a Centrimag. Initiating an ARNI in acute heart failure with mechanical support also helps in improving the LV ejection fraction in these acute cardiogenic shock patients dramatically from 18% to 43%. This is a study which was published in the European Heart Journal. And majority of these patients, when they are given ARNI with a Centrimag on board, can be successfully weaned off, and it supports the role of ARNI in a bridge to recovery. And this is because of the fantastic improvement in the pathophysiology of these patients. Sorry, I'll just give. The other thing is when you're looking at blood pressure control and heart failure control in LVAD patients. ARNI immunization was successful in most of the LVAD patients, especially in significant consolidation of the blood pressure management, because it helps in maintaining the mean arterial pressure, helps in reducing the blood pressure related medicine, especially nephropenin, amlodipine, and also reduces the dosage of loop diuretics for these patients. It also helps in improvement of the NYHA class, which I'll come to in one of the subsequent slides. And pre-operative use of ARNI, there are many of us who are a little skeptical when we have ARNI on board and we are taking the patient for a transplant. Definitely, there is a chance of vasoplegia, which we need to be careful about. And sometimes, if vasoplegia occurs, we can treat it with vasopressin, but the pre-operative use of ARNI was not significantly associated with development of vasoplegic syndrome in this particular study, which was published, and it had a significant 30-day survival when we had ARNI on board before surgery. And also in patients with LVAD, of course, not related to heart transplant, the early initiation of ARNI was well tolerated in this subset. So what are the potentials for the future? Sacubitril valsartan has a role in remodeling of cardiac tissue. There is no doubt about it. This has been proved by various hemodynamic studies. There are cardiac MRI studies, echocardiographic studies, as well as right heart catheterization studies, which have clearly shown that there is definite improvement in hemodynamics as well as the remodeling, reverse remodeling. There's reduction in NT-proBNP levels, prevention of ventricular arrhythmias, and also improvement in the pump flow as compared to other therapies. It has the potential of reducing the number of heart failure readmissions as well as stroke among LVAD patients. And it also helps in conserving the kidney function, because many of us are worried that the renal function and there will be a decline in the eGFR when we use this molecule. But actually, because of the improvement in the cardiac output, the eGFR improves. This was a slide which I was telling you about when we using ARNI. Post-ARNI, when you look at the recovery for these patients, there is definitely a NYHA class 1, 2 improvement from 3 and 4. Functional capacity improves, symptomatic relief occurs. There is reduced dependence on the loop diuretics because of the improved natriuresis, and also there is, the reduced frequency of usage of these tablets also comes down. So from a surgical perspective, yes, we would definitely have GDMT on board for an LVAD patient, and it complements surgical unloading with biological recovery. We should initiate ARNI as soon as possible in hemodynamically stable patients. We should ensure that the patient has an adequate mean arterial pressure before we initiate. Start at a low dose and titrate gradually upwards. Keep a close monitoring of the blood pressure, renal function, and electrolytes. And here I would like to talk to you about Azmada from JB. And of course, we are getting an academic grant from JB Chemicals. So I would have to tell you that there is a fixed 1:1 molar ratio of the molecule. It is a supramolecular complex with unique physico-chemical properties, good solubility profile. It has an enhanced bioavailability of valsartan and a higher dissolution rate at different pH. So it's a first-in-class ARNI by the innovator and is a unique co-crystal invention. And when you look at it head to head, there is a paper by Dr. Nair T. et al. In 2024, which concluded that the absence of identical crystal lattice structures highlights the absence of true crystals in generic formulations. Such variations may impact the bioavailability and efficacy, emphasizing the importance of ensuring consistent and reliable therapeutic outcomes. So when we look at Asmada as well as they compared it with other molecules, they found that this molecule had a better biovalent property. So I like to conclude my talk with a few takeaway messages. Post LVAD, GDMT remains a cornerstone for long-term outcomes. It should be initiated as early as possible, as long as the hemodynamics are maintained and the renal function and electrolytes are well within control. The LVAD not only unloads the heart, but also causes reverse remodeling, and ARNI definitely causes the biological help for this mechanical support. Neurohormonal blockade remains essential post LVAD, and ARNI enhances myocardial recovery, and also it can help in bridge to recovery rather than a destination therapy for some patients. So we have to integrate surgical and medical therapy, and this is what will happen even in the future. It's not only pure surgical interventions which matter, perioperative medical therapy optimization also will play a crucial role in having the long-term outcomes. Thank you very much for a patient hearing. Over to you, Dr. Dalla and Dr. Aditi. Thank you.
Thank you, sir. Dr. Duraraj, that was an excellent yet brief discussion on this important topic with very precise take-home messages. I think one of the last points that you mentioned that about a combination, it's not only surgical therapy, it's also a combination with medical therapy. So the ARNI can be a good friend to LVAD in helping the left ventricle recover. I'll let Dr. Aditi Singhvi take over now and see if we can throw some questions at our panelists before we start taking questions from the audience.
Sure. So great talk, as Dr. Tala has mentioned. Maybe we can talk a little more about the practical approach and how you incorporate this in your practice. So as we emphasized on the role of GDMT in LVAD patients as well. So practically, when should ARNI be initiated after an LVAD? What are the parameters that guide your decision? What are the things that you watch for? And yes, what are your preferred medications as far as GDMT is concerned after LVAD?
Can I answer that, or Dr. Javli? Or...
Absolutely. I mean, we can hear
Okay,
from all the panelists regarding their opinions.
So I'll just start off. I mean, ARNI can be started once the hemodynamics stabilize, especially, typically 2 to 4 weeks post LVAD. And the key parameters which I would like to watch out for are the mean arterial pressure. It should be approximately 65 to 70 millimeters of mercury. There should be a stable RV function. And, having a borderline RV function, also you can start if the parameters are okay, because sacubitril valsartan will definitely improve the RV function. eGFR is something very, very crucial. You cannot accept a low eGFR, especially less than 30. So the eGFR has to be more than 30. And the potassium levels, something we should take care. It should be approximately, less than 5, more than 5.2, 5.3, where we are thinking that it will tip off into hyperkalemia. I think we should avoid. saying that there is a molecule called low-kelma which has been introduced for reducing hyperkalemia. Even if there is hyperkalemia with ARNI or any of the other, like maybe Verisogod or and use low-kelma sachet, which brings down the potassium rapidly within an hour. The other thing is no inotropes or minimal support. So these are the simple things which I would say should be the key when we start earning.
Thank you so much for those pointers and suggestions, Dr. Manoj. Sir, maybe Dr. Javli, would you like to add something to what sir has mentioned? And yes, sir. Sir, you're on mute.
Manoj has been extremely clear and succinct. Most of the points are covered. Rather than telling about my protocol, I have some questions for all of you, my concerns. Most of the LVADs that we do happen to people from abroad who can't get a heart here. We have to train them, keep them a couple of months, send them back. When we start earning, the effects could be variable. And I'm always worried about the vasodilation creating a suction effect and creating problems with the LVAD functions. If it happens away from the hospital, where they may need to be admitted, vasopressin to be started, I'll be very worried. So the first 3 months in a hospital setting, we should set this whole thing up well. Let them, we are all very experienced with ARNI, everybody in this panel. Vast experience. We know exactly how this drug acts, how do we handle it. But LVAD is a different ballgame. And the articles that we read in the literature, they are very scanty, they are very small, they are not respectable articles. We don't have large studies. So much of it will have to go by our gut, by our experience of applying ARNI to the heart failures. So this problem in my mind remains about the suction effect. Any comments on this by all of you?
So, based on the patients that I've taken care of, as sir was mentioning, as once they're hemodynamically stable, GFR is stable, RV function is reasonable, most of these patients tend to be hypertensive. So actually, ARNI works very well for those patients. And definitely a close follow-up is needed immediately after an implant and the index hospitalization for various reasons, not just for the medication management. So that's an important point that you have brought up, definitely. And as you have rightly mentioned, the ARNI trial in LVAD patients was small. We could get some insight from the restage trial, which had a larger number of patients, where they used not ARNI, but ACE inhibitors and ARBs and high doses. So 40 milligrams of lisinopril or up 150 milligrams of losartan were used in that trial, and they seemed to not have any major adverse effects in terms of tolerability. So that is something that we can use to base our practice on. Is Dr. Kunal Sarkar available? Has he joined the meeting?
Not yet joined, ma'am. In the emergency, he'll join shortly.
Okay, and do we have Dr. there?
No, both are joining. Not yet, ma'am.
Oh,
Okay, it's all right.
I think just to continue on that point, Dr. Aditi brought up a very important study, that she cited for use of ACE inhibitors and ARBs, high doses in post-LVAD. One of the main ways that they work is by reducing the afterload to the LV. We all know that these LVADs, when faced with a high MAPS, not the current generation LVAD, but we all know that the bad effects of high MAPS, systemic hypertension, especially with the heart wear LVADs, were quite significant, with a significant increase in the risk of strokes, particularly hemorrhagic strokes. And there's clear data stating that better blood pressure control with MAPS strictly between the range of 75 to 90 showed a significant decrease in the incidence of these hemorrhagic strokes. So I think there is still some role, while the actual evidence in literature may be limited by smaller groups. of patients enrolled, I think there is definitely a role. This whole concept of recovery post LVAD is still in its infancy, especially in India. I think when Dr. Aditi and I were in US, we probably would hear this a few times in a year. But since we've moved on, there's actually whole day and weekends of conferences just focusing on LV recovery. So there is definitely a lot more to learn, and this is, definitely more data that should come out. I agree with Dr. Jani that that the studies are not as strongly powered, but definitely some role.
It could be interesting if you could anecdotally talk about some patient stories that you are very impressed with in LVAD setting post-operatively with the use of ARNI. That will make an interesting hearing for the audience and all of us.
Absolutely, sir. So, at least I can just, the last LVAD that we implanted, he was long-term ischemic cardiomyopathy, 68, 69-year-old. We had implanted it as a destination therapy. 3 months post LVAD, his renal function was deranged, but 3 months post LVAD, he returned to his baseline renal function of around creat with 0.9 to 1. And after that, we started having issues with severe hypertension, and started, calcium channel blocker, started hydralazine, kept adding, alpha prazosin, and eventually the main shift happened when we started him on ARNI. And with that, the other medications requirement for other antihypertensives reduced. And right now he's on full doses of ARNI. He's not recovered. He's not going to recover. It's an infarct-related cardiomyopathy. However, the need for multiple classes of antihypertensives have reduced, number one, and number two, his MAPs are well controlled. So I know that his risk for strokes and is not as high as it was without.
What is this full dose?
So right now he's on 200 milligrams twice a day of ARNI.
Okay.
So we have one LVAD patient here as well, who is tolerating high doses of heart failure medications. So he's on 200 milligrams of Vimada and carvedilol 25 mg twice a day, along with dapagliflozin and spironolactone, requiring very minimal diuretics and relatively stable. He's also ischemic cardiomyopathy, and EF remains moderate to severely reduced. So we are not thinking of recovery for him. But in the US, I remember a couple of patients where we were successful in weaning off LVAD in those patients. And a couple of patients, we were not early on in the program, we weren't really actively working towards recovery. So generally just happened to note that, patients were persistently hypertensive, had good pulses, had aortic opening with every single beat, and LV size had reduced from, prior pre-LVAD from 7 centimeters to say 4.5 centimeters or so. So those patients, a couple of patients like that were there whom we worked towards recovery. And one patient, I remember we were actually forced to wean him off of LVAD because he had persistent hematuria. And he had other favorable signs. He was a non-ischemic myopathy, short duration of heart failure. The LV function had improved to 45% or so. End organ function was normal. That patient we were able to successfully wean off. And then after that, and as more data started coming out and more centers, particularly Utah, started talking about recovery, we started actively working towards recovery. So the goal now in most US programs' mind is to actively consider every LVAD patient as a candidate for recovery, particularly if they have favorable features like non-ischemic cardiomyopathy, short duration of heart failure, younger age, a reasonable RV function, and good end organ function, and no ventricular arrhythmias. So as a protocol, we try to start all patients on the 4 pillars of GDMT and then keep up titrating them, just like with heart failure patients, regardless of presence or absence of symptoms, to their maximally tolerated doses.
So in summary, I think all of us are hugely experienced in using ARNI in our heart failure patients. It's an extremely friendly drug, and it is continuing to surprise us of how useful it is. So it's very exciting to think about using it in LVADs and creating a hope that we will have many patients whom we could wean off from LVAD.
Yes.
So that's the important point of conclusion. Manoj, you were saying something.
I think there was an interesting question in the chat box on the RV. How does ARNI impact right ventricular function in LVAD patients? I think, I would request Dr. Aditi or Dr. Tala to take up this, because I think that's the key to the whole thing, isn't it?
Absolutely.
The recovery is good, but then RV is maintaining the LVAD, isn't it?
Right. So, there are some observational studies or trying to answer this very specific question, whether ARNI helps in RV function recovery as well. And there are some positive observational studies. Again, there are smaller single center studies. But pathophysiologically, it does make sense. We all know that, ARNI, especially in these patients with long-term standing cardiomyopathies, they can have several years of pulmonary hypertension. ARNI, by lowering the SVR, the left ventricular end diastolic pressure, obviously is unloaded by the left ventricle, but by lowering the SVR, it can reduce the PA pressures, and over the long term can also help the right ventricle as well. This is especially true in non-ischemic cardiomyopathy. So yeah, I think there is some role there, but it remains to be elucidated with larger data sets. Dr. Aditi, what do you think?
Yes, absolutely what you mentioned. So a large part of the improvement of the RV function is because of its effect on the LV and the pulmonary vasculature as a result. And in addition, the neurohormonal activity, so decreasing stimulation, decreasing sympathetic tone in patients does lead to less RV fibrosis and adverse remodeling over time. Now, of course, that is from animal studies or heart failure studies, not necessarily from studies in LVAD patients. But small observation studies have also shown that there is less RV failure with use of ARNI, as well as less ventricular arrhythmias and even less GI bleed, which again, we think that there is a higher rate of GI bleed in patients who have RV failure. So those are the suggested mechanisms. We can take up some of the other questions from the chat box, I think. So one of the questions is regarding, are there specific hemodynamic or echocardiographic parameters that guide ARNI initiation post-LVAD? If Dr. Javli sir or Dr. Manoj sir, would you like to answer any of those questions?
I feel the ARNI is so important and such a useful drug that if the renal parameters are permitting, I think it should be universally used.
Absolutely. And what another question is regarding the blood pressure target. What blood pressure target do you consider safe when prescribing ARNI post-LVAD?
Above 90.
The map around 65-70, mean arterial pressure is what we look at, right?
Yes.
So I think that's a minimum 65 to 70 should be there. If it's less than that, then there will be severe vasodilatation, and that might not lead to, it will be less counterproductive. I think a minimum a map should be 65 to 70.
Absolutely. Then I think the last question is about how do you balance ARNI induced?
I want to stop you and ask you a question. How often, what percentage of your post-LVAD recovered patients you have patients mean blood pressure less than 60 or 65?
From my personal experience, or I think from anybody's personal experience, they maybe have one or two patients who have actually successfully.
Not very common, yeah. So my only concern will be renal.
So, but if you're talking of patients who have been weaned off LVAD, presumably your center has done a good job of ensuring that their cardiac function has recovered enough to ensure safe LVAD recovery. So they should have a normal blood pressure and they should continue to tolerate heart failure medical therapy. That is actually one of the criteria that we have, that ability to tolerate high doses of all 4 pillars of medical therapy. But speaking of vasodilation, I wanted to just bring up one of the slides that you had mentioned in your presentation, sir, regarding patients who are on ARNI in the waitlisted period and its effect on vasoplegia. The data that you showed that there was no real difference in outcomes, but based on your personal experience, what do you feel?
Excuse me, Dr. Kunal sir has joined. Just to...
There's and there's 100% chance of vasoplegia. I would this thing contradict my own this thing, but the presentation, but vasoplegia is going to be there when you have ARNI on board and you've taken it just one night before the transplant. You have to be expecting systemic pressures of around 50, 60. We've had patients for 1 week with those kind of pressures, pouring urine, but the pressures are down and you're scratching your head what to do. The only thing which works there is vasopressin.
Yeah.
That's the only thing which works during that time. I mean, I'm open to the panel if they can let me know, but I think vasopressin works. People have used methylene blue, but that's kind of anecdotal. But yeah, vasoplegia is there, definitely.
Yes.
LVAD is most of the time a planned surgery. How long in advance would you stop the ARNI in these patients?
So I think, sir, when talking about LVADs and in the pre-LVAD context, most of the patients that reach us would either be intolerant to guideline-directed medical therapy, including ARNI, either due to hypotension or renal dysfunction or a combination of both. If for whatever reason they are able to tolerate ARNI and we are doing a planned LVAD, then we would generally stop ARNI for maybe 3 to 4 days at least minimum, if we have that much of a gap before the planned surgery. Before transplant, now we are just stopping ARNI. As soon as the patients are listed for transplant, we are stopping ARNI. We don't see there's no net clinical benefit that we've seen. As Dr. Duraraj sir has rightly mentioned, a lot of vasoplegia that troubles the surgical team, not only in the operation theater, but even also immediately post-op.
And also the dapagliflozin.
Yeah, the DAPA as well. Absolutely. Yes, sir. Yes. Aditi, what do you guys do with ARNI pre-transplant?
Same as what you had mentioned, as soon as a patient is listed, we stop the ARNI. Anyway, there is no role once you have established that the patient is stage D heart failure.
Right. Dr. Kunal Sarkar has joined us. Welcome, sir. So we had just finished the presentation by Dr. Duraraj sir, and we were taking up questions from the audience. We had an interesting discussion on whether ARNI-related vasodilatation could be counterproductive to our post-LVAD patients, and there was some data shown by Dr. Duraraj that how ARNI can help in post-LVAD recovery, LV recovery. Dr. Sarkar, sir, would you like to comment on any of the topics or discussions that we will...
No, honestly, I think first of all, apologies for being late. We were stuck in our usual hassles. One of the comments which I would continue is what Manoj said. I think his comment about the vasoplegic state and the need to use vasoconstrictors, vasopressin, etc. is quite valid. You see, one of the other concerns is vasopressin does get the pressures up. But in the diabetic subgroup and people, say, who've had diffuse arteriopathy, the concern with vasopressin is, especially you've had people on ECMO and femoral cannulation and all that stuff, is peripheral limb ischemia. So that really, apart from the vasoplegic state, the pressures being down, relying on vasopressin to give us an acceptable mean pressure. But the appearance of digital gangrene and stuff like that is very bothersome. But I would definitely agree that that is a problem. And I was wanting to ask you a counter question. Somebody just asked you that how long before do you actually stop it? I mean, what is the consensus on that?
You mean before LVAD therapy, sir?
No, before transplants. The point
Before
Manoj was
transplant,
making.
so we stop it right at the time the patient gets registered for transplant.
I mean, okay, fair enough, but that means that you run the risk because, say, in my part of the world, from the point of registration to the point of getting an organ, maybe a few weeks, if not a few months. Then would we be happy to keep them off it for so long? Because that is a double-edged sword, isn't it?
Right, sir. But I think, the net clinical benefit is not in favor. And also there was actually a fairly decent sized trial, I think the LIFE trial, which was published in JAMA in 2022, looking at around 300 odd patients of advanced heart failure, NYHA function class 4 heart failure patients. It was a double blind, multi-center study, and which showed that in these patients with advanced heart failure, ARNI did not really help much in terms of improving the NT-proBNP. In fact, there was a statistically significant increase in the chances of hyperkalemia, which were not life-threatening. However, we did see a chance of life-threatening hyperkalemia. And because of that, and plus our own anecdotal experience with severe vasoplasia, we just make it a point to stop the ARNI, and instead we'll just closely watch them. They are here every 3 to 4 weeks in our heart failure clinics for a physical follow-up while they wait for their organs.
Accepted. I think that's a fair comment, and that's a fair comment. Yes, but it still remains, it remains a problem. Thanks.
Thank you, sir.
What do you feel about Verisogard for these patients where you can't use an ARNI? I mean, Verisogard do you think it's a fill-in-the-blank molecule? Because I don't know whether there is any perioperative issue with Verisogard. I mean, I have not seen it, so I don't know. Hypothetically, I think, if you have any.
I'm going to take the liberty of answering that question. So, Verisogard, if you look at the Victoria HF trial, and if you look at the patients who actually benefited from Verisogard, and they looked at the patients based on their tertiles of NT-proBNP cutoff. So the patients who are in the very high NT-proBNP range, which would be our advanced heart failure patients, they did not benefit from Verisogard. And even the patients who did benefit, we know that there was a 10% absolute reduction in the clinical endpoint. So, and you also have to put it into context the cost of Verisogard. So I think cost benefit ratio, I generally, and for advanced heart failure patients on the wait list, I don't think there is any benefit of Verisogard. I think it may just unnecessarily add to their expenses, especially while they're awaiting a big budget procedure like transplant. So I don't personally use it. Dr. Aditi and Dr. Sarkar and Javli sir, happy to hear from you about this.
So,
Verisogard to me is still a stranger. I'm still finding my way.
so I agree with what you have said. Above an NT-proBNP of more than 8,000 in the Victoria trial, they felt that Verisogard did not have any efficacy. So in these advanced heart failure patients, it's unlikely that it would have significant benefit. Also, even in less advanced patients, though Verisogard does have a role, typically the way you get a symptomatic improvement after starting ARNI or SGLT2 inhibitor, I have not really seen that as much with Verisogard, that patients immediately report after 2 days they feel better. So clinically also, I don't feel a need to continue it in patients who are listed once we've established that they require transplant or LVAD therapy. I will use it in less sicker patients, definitely, again, as worsening heart failure patients is essentially who've been hospitalized, who are not able to tolerate any of the four pillars because of hyperkalemia or some reason like that. I do sometimes start it in upfront patients, de novo heart failure patients, if again their blood pressure is very low and they're not able to tolerate medical therapy, where I've not clearly established that they're end stage. There still might be some potential for recovery. So I might use Vericiguat as a bridge in those patients and still keep trying to start them on ACE, ARB, or ARNI. So those are the clinical situations where I use it.
Aditi, one question, if you
Dr.
don't
Sarkar,
mind.
sir, your thoughts?
Yeah, just one question to Aditi. I know may sound like a stupid question. Is Vericiguat, by the way, is it supplementary and or an alternative treatment? What is it?
It is a supplementary treatment in patients who have worsening heart failure, so who are already on the four pillars and then either not able to tolerate one of them because of hyperkalemia, hypotension, or they're on it but they have worsening heart failure. That is how it was studied, but it is being extrapolated as an alternative treatment upfront also if you're not able to start ARNI. Typically, it is one of the RAS inhibition drugs that you're not able to start because of hyperkalemia
Right.
or advanced CKD, one of those reasons.
Thanks.
Thank you. And regarding its effect on perioperative blood pressure and vasodilation, I don't think it's been around long enough to actually be able to tell whether it has any vasoplegia post cardiac surgery or non-cardiac surgery for that matter. But I think just because we don't know enough, probably safer to stop these medications 24, 48 hours ahead of any planned surgery.
Absolutely.
One question to Manoj. Manoj, you mentioned the use of vasopressin for vasoplegia. Is there any other alternatives that has been tried at all in the transplant situation? Anything else that you've come across? Because
Anecdotal use of methylene blue, sir.
have you used it? Have you
I
used
have not
it?
used, but then there was something happening in the cardiac surgeons group on use of methylene blue, and I think somebody presented that also as a bailout option, and it actually worked. Of course, it just transformed the whole, recovery room into a shade of blue, but including the patient and the urine and everybody else. But then it was scary, but then it was, I think they could bail out the patient with that. And they in fact described the dose also of IV methylene blue. Dr. Tala, I mean, I don't know whether it
Yes.
was your unit or I'm not sure. Was it your unit, Neeraj Kamath, who presented that? I'm not sure.
So, sir, we've used methylene blue very scarcely and with a lot of worry about downstream side effects of fingers getting mottled and all that, because it can cause extreme vasospasm. There is a fair bit of evidence. In fact, I forget the center which has published it. They've used and they've shown how methylene blue has helped in their post-op vasoplegic patients for not transplant but all general cardiac surgery post-op vasoplegic syndrome. I think this was Canada, but I can't be sure. And so we follow the same dose that they have described in their protocol. We barely used it in 3 or 4 of our whatever 170 odd transplant patients, but the 3 patients that we used them on have not survived. Maybe we used it too late. I am not sure, or maybe they were all sort of too late into the spiral, and that's why that didn't really turn them around. But the dose that was described was a 2 milligram per kilogram bolus followed by a 0.5 milligram per kilogram per hour infusion for I think 12 or 24 hours. And yeah, that's all. So probably an experience of a grand total of 3 or 4 patients over the last 7-8 years, and not very great outcomes. But the blood pressure as a number does come up.
You see, you
So
were
in the
mentioning
US,
about. Sorry, I was just again a question that you were mentioning stopping the ARNI when the patient is listed, right?
Right, sir.
That what would you recommend instead? Is it going on to the old-fashioned sort of ramipril group or lanoxin? What do we fall back on when we do that?
So most of my patients, they have such soft blood pressures that, they're, instead of being in their 80s, their pressures are, after stopping whatever 50 or 25 milligrams twice a day of ARNI, their pressures then, hang around in the 90s. I don't generally need to start anything else. If I do, I'll probably not go to any of the RAS inhibitors for fear of, renal dysfunction. But I keep a very close follow-up on them. So some patients nearly come to me every week to
No, just tell us what
10
would
days
you
just to drop in
what
and,
would you
say hello
prescribe
to my
instead?
clinic.
That's because we are not very good in
Exactly.
prescribing.
So I probably would not do anything more unless and until, their pressures are, say, 130, 140, or, I have some other clinical issues after stopping and I haven't had any such issue, at least over the last 4 to 5 years.
Beta blockers and diuretics?
They will continue. Yeah, I obviously can't stop the diuretics and beta blockers. We continue.
So just to add to the discussion regarding vasoplegia, so in the US, we used methylene blue for patients, not commonly, but not infrequently either. And the other group of patients where we saw a lot of vasoplegia was patients going into transplant with an LVAD infection, device infection. They also had a lot of vasoplegia. And our group wrote a paper on that also when I was at Mount Sinai about vasoplegia in LVAD bridge to transplant cases. So we use methylene blue, and again, it's generally a bailout drug, so it's hard to say how much it actually helps because half the patients make it, half the patients don't. Another medication that is sometimes used in refractory vasoplegia is IV hydroxycobalamin. I've not used that here, but we use that sometimes in the US. Sinokit, it's is the brand name.
Aditi, long time back when people were getting very apprehensive about the what you call it, the ramipril group, long time back.
Yeah.
Then there was some discussion about using angiotensin. Right.
Yes,
I think that was made
that is also
therapeutically available for a brief period. Is it still available? I don't know. I mean, I have no idea.
I don't think Jaipreza is available. That was the brand name. I don't think it's available anymore because it didn't have really good outcomes.
What
It
was the
was
brand name?
indicated for septic shock. Jaipreza.
Oh,
It
right.
was
Okay.
it was indicated for septic shock, refractory vasodilatory shock. Basically used in septic shock as a bailout drug. So those patients were probably too
Right,
late.
right.
Or don't
Yeah,
have
yeah.
any.
Correct. Yeah, yeah. Well,
I don't think it's available in India, sir, but I think it may still be available in Europe somewhere. Because I just, one of my ICU intensivists, they asked me to comment on the use of angiotensin 2 in our vasodilatory shock patients, cardiogenic shock with low SVR kind of patients. So they had shown me that paper, but I'm not. I'm sure that it's not available in India. Aditi, it looks like we are almost at the closing time. Would you please, end the session with a final sort of summary of the discussion and do the needful? Thank you.
Sure. So we had a very engaging discussion on a topic that we don't think about or talk about commonly, but hopefully going on forward, this is something that we will be more mindful of. So we discussed about recovery in LVAD patients and the use of high doses of guideline-directed medical therapy, in particular ARNI, to promote recovery and allow for good outcomes in patients with LVAD. Even if you're not able to achieve recovery in those patients, it has been shown to have some improvements in terms of quality of life, functional status, hemocompatibility related adverse events, ventricular arrhythmias, and RV failure. Then we also discussed potential of vasoplegia in the perioperative setting. And I think overall this very insightful discussion, and going forward we should look at recovery in all our patients who undergo LVAD, particularly younger patients who are non-ischemic and have a shorter duration of heart failure. So with that, we'll end the session. So thank you so much to our speaker, Dr. Manoj Durairai sir, our panelists, Dr. Vivek Javli sir, Dr. Kunal Sarkar sir, and my co-moderator, Dr. Talha. And then a big thank you to JB Pharma for facilitating this educational activity. And we hope to continue such educational activities in the future also.
Thank you, sir. On
Thank
behalf
you.
of JB Pharma, thank you to all respected panelists and doctors. Thanks a lot, sir.
Thank you.
Thank you.
We are ending the meet. Thanks a lot. Thank you, Dr. Javli sir, Dr. Durairai sir, Dr. Sarkar sir, Dr. Aditi ma'am. Thanks a lot. Good night, sir. Thank you.
Good night.
Good night.
Thank you so much, everyone, for joining today's session and giving your valuable time. So from here, I'm ending this meeting. Thank you.